Atrial depolarization is transmitted to the ventricular myocardium by the AV node and intraventricular conducting system. The time between the onset of atrial depolarization and the release of depolarizing current into the ventricular myocardium from the terminal branches of the conducting system is represented by the PR interval on the ECG. Dysfunction of the AV node or diffuse damage to components of the ventricular conducting system can result in a delay or even failure of transmission of atrial depolarization into the ventricular muscle mass. This situation is referred to as atrioventricular or AV block. 3 degrees of AV block are recognized. In first degree AV block, all P waves are transmitted to the ventricular muscle mass, and therefore all are followed by a QRS complex. However, the time taken for conduction into the ventricular myocardium is prolonged. First degree AV block is defined by transmission of all P waves to the ventricular myocardium, but with prolongation of the PR interval beyond the upper limit of normal of 0.2 seconds on the ECG. Second degree AV block is defined by failure of conduction of some P waves into the ventricles. As shown here, the periodic failure of transmission of atrial depolarization into the ventricular muscle mass, with consequent absence of an associated QRS complex, creates a visual impression that the QRS complexes occur in clusters or groups. This is what we mean when we use the term group or groupings in this video. There are 2 major subdivisions of second degree AV block, Mobitz type 1 and Mobitz type 2. The distinction is important as they are associated with very different outcomes for the affected patient. Mobitz type 1 second degree AV block is the so-called Wenckebach phenomenon. Looking at this rhythm strip, the QRS complexes appear to occur in groups, and on closer inspection we find that isolated P waves are periodically failing to depolarize the ventricles. With periodic failure of P wave transmission to the ventricular myocardium, this is a case of second degree atrioventricular block. Analyzing the relationship between the P waves and the QRS complexes, we find a progressive prolongation of the PR interval within the group until finally a P wave fails to be transmitted to the ventricular myocardium. This progressive prolongation of the PR interval preceding a non-transmitted P wave is the defining characteristic of Mobitz type 1 second degree AV block. The phenomenon is usually caused by increasing prolongation of the conduction time within the AV node. Mobitz type 1 second degree AV block may occasionally be associated with symptoms, but is considered clinically benign in the sense that it has a low rate of progression to complete AV block. In Mobitz type 2 second degree AV block, again by definition there is an intermittent failure of conduction of P waves to the ventricular myocardium. However, unlike the Wenckebach phenomenon, there is no progressive prolongation of the PR interval before the non-conducted P wave. Analysing this strip, we note that within the groups the PR interval is constant. With intermittent failure of P wave conduction and a constant PR interval, this is Mobitz type 2 second degree AV block. You'll also notice that within each grouping there are 4 P waves, 3 of which are conducted to the ventricular myocardium. This is Mobitz type 2 second degree AV block with a conduction ratio of 4:3. Unlike Mobitz type 1, Mobitz type 2 carries a significant risk of progression to complete AV block and is therefore associated with a significant mortality in the absence of intervention. We should point out that the conduction ratio in second degree AV block, and therefore the size of the groups, varies between patients, and as shown here, may even vary between groups in a single patient. In the presence of very high conduction ratios, differentiating between Mobitz type 1 and type 2 can be a much more challenging task than we've illustrated so far. Making the call matters because the difference in underlying pathophysiology is reflected in a markedly different prognosis for the patient. As shown here, in second degree AV block with high conduction ratios, the groups may be so large that full groupings are not demonstrated on a standard rhythm strip. Furthermore, and more importantly, in the case of Mobitz type 1 with high conduction ratios, after the first few beats, the degree of progression in PR interval length within the main body of the group can be so small as to be imperceptible. The key to making the call between type 1 and type 2 in a case such as this is careful analysis of the PR interval around the time of the non-conducted P wave. In a case of Mobitz type 1, the longest PR interval is seen in the beat immediately preceding the non-conducted P wave, while the shortest PR interval is observed in the beat immediately following the non-conducted P wave. Also, the largest change in the PR interval is observed between the first and second beats following the non-conducted P wave. Despite the apparent uniformity of the PR intervals within the main body of this group, analysis of the PR intervals around the time of the non-conducted P wave indicates that this is a Mobitz type 1 second degree AV block. This situation is termed atypical Mobitz type 1. Just one further point before we move on. Looking at this rhythm strip, you would be forgiven for thinking that we are dealing with a case of second degree AV block. And with a constant PR interval before and after the non-conducted P wave, you may suspect that this is Mobitz type 2. In fact, you will be wrong. This is a non-conducted premature atrial contraction. Ectopic atrial discharges may not be conducted for a variety of reasons. A benign finding on the ECG. Careful analysis demonstrates that the non-conducted P wave is in fact premature, occurring well before the next expected P wave. Also, as expected, the ectopic P wave has a different morphology than those preceding it. Compare this to our case of Mobitz type 2. The P waves occur with monotonous regularity and are of uniform morphology. In addition to the major subdivisions of second degree AV block, two further variants are also recognized. Second degree AV block with a conduction ratio of 2:1 is termed untypable. With only one PR interval before each non-conducted P wave, there is no way of knowing if this is Mobitz type 1 or type 2. This rhythm strip shows another variant of second degree AV block. High-grade second degree AV block exists when at least two consecutive P waves fail to conduct to the ventricular myocardium. In third degree or complete AV block, no P waves are transmitted to the ventricular myocardium. When this problem arises secondary to diffuse damage of the conducting system, a ventricular focus will take over pacemaker function, driving ventricular depolarization. The escape rhythm generated will be broad complex and will vary in rate between 20 and 40 beats per minute. At this stage, you should be able to spot the AV dissociation evidenced by the presence of regularly occurring P waves which show no fixed relationship with the QRS complexes. The distance between P waves and QRS complexes varies continuously, and some P waves are buried in components of the QRS complexes, while others are fused with the T waves. You will also appreciate that if complete AV block arises secondary to localized damage or dysfunction of the AV node, an escape rhythm can arise from a focus within the bundle of His. As depolarization from this focus enters both branches of the bundle of His, the rhythm generated will be narrow complex. However, as the discharges from the bundle of His are not transmitted to the atria, the SA node continues to fire uninfluenced by events below the damaged AV node. Hence, as shown here, the presence of AV dissociation should be detectable. This slide summarizes the material covered in this video. There is disagreement in the literature, particularly with regard to the precise definition of some subtypes of second-degree AV block. We would recommend that you stick with this nomenclature. Isolated dysfunction or damage of either of the main branches of the bundle of His is commonly observed. The pattern of ECG changes associated with right or left bundle branch block are broadly predictable, and you must be able to recognize them on the ECG. If we analyze again the major ventricular depolarization vectors dictating the QRS complex morphology, you will remember from section 1 that the early flow of depolarization in the mid-zone of the interventricular septum from an intact left bundle branch produces a small physiological Q wave in lead V6 and OR wave in lead V1. This signal is rapidly overwhelmed by the onset of left ventricular depolarization, which, moving towards V6, produces a strong OR wave in this lead and S wave in lead V1. Signal transmitted by the right bundle branch depolarizes the right ventricle, but the signal from right ventricular depolarization is usually buried in that generated from the larger left-sided chamber. The rapid conduction of depolarization around the chambers by an intact conducting system means that all regions of the ventricular myocardium are depolarized within 0.12 seconds. We will now deal with the ECG findings associated with right bundle branch block. When conduction in the right bundle branch is blocked, septal depolarization proceeds as normal from the intact left branch from left to right, producing an initial OR wave in lead V1. Depolarization arriving as normal in the left ventricle then generates an S wave in this lead. In the presence of right bundle branch block, depolarization of the right ventricle is delayed and travels to the chamber by direct cell-to-cell contacts. Slow depolarization of this chamber moving towards V1 produces a wide second OR wave in this lead. Note also that this delayed right ventricular depolarization moving away from lead V6 produces a late slurred S wave in this lead. The QRS complex is broad, reflecting the delay in right ventricular depolarization. The ECG signal of right ventricular depolarization is normally masked by the signal from the much larger left ventricle. However, as right ventricular depolarization is delayed in the presence of right bundle branch block, Depolarization of this chamber manifests as a delayed broad R wave in lead V1 and an S wave in lead V6. Abnormally wide QRS complexes with an RSR pattern in lead V1 and a delayed slurred S wave in lead V6 are the characteristic ECG findings of complete right bundle branch block. Note also that the highly abnormal pattern of depolarization in right bundle branch block results in an altered pattern of repolarization in the right ventricle. Right bundle branch block is therefore associated with ST and T-wave abnormalities in the right-sided chest leads. These abnormalities are a secondary phenomenon and do not necessarily indicate underlying ischemia or strain. The classic pattern shown here is seen in many cases. However, it is important not to become over-reliant on the presence of the RSR pattern or so-called rabbit's ears appearance in V1 to make the diagnosis. In many cases of right bundle branch block, the RSR pattern in V1 is not identifiable. The QRS complex in this lead either demonstrating a small notch between the two R waves or indeed having the appearance of one large R wave. The presence of a slurred S wave in lead V6 is said to be more reliable in the diagnosis of right bundle branch block. Also, the QRS complex in lead V1 must be overall positive to make this diagnosis. So, to identify complete right bundle branch block, apply the following criteria. The right bundle branch of the ventricular conducting system is a relatively thin filament, and within the intraventricular septum it lies close to the subendocardial surface of the right ventricle. It is therefore liable to compressive damage secondary to increased pressure in the right ventricular chamber. So right bundle branch block on the ECG may arise secondary to a chronic increase in right ventricular pressure, for example in primary pulmonary hypertension or cor pulmonale, or due to an acute rise in right ventricular pressure in, for example, an acute pulmonary embolism. In addition, right bundle branch block may occur secondary to a wide variety of heart diseases, either congenital or acquired. The right bundle branch is supplied by septal branches of the left anterior descending artery, and so new onset right bundle branch block may be observed in myocardial infarction secondary to obstruction of this artery. Amongst many other potential causes, the right bundle branch may also be affected in diffuse cardiac diseases, such as myocarditis or cardiomyopathy. Iatrogenic causes are also recognized, such as damage during pacemaker placement or right heart catheterization. You can see from this list, which is by no means exhaustive, that right bundle branch block on the ECG can be a useful pointer towards a diverse range of significant diseases. However, it is important to realize that complete right bundle branch block is also observed on the ECG of a proportion of healthy individuals with no underlying heart or lung problems. The interpretation of the significance of right bundle branch block on the ECG is completely determined by the clinical context. The ECG findings in left bundle branch block are also predictable. When flow in the left bundle branch is blocked, depolarizing signal released from the terminal branches of the right bundle branch moves into the septum. The direction of travel of the depolarization wave within the intraventricular septum has therefore been reversed and is now moving from right to left, the opposite direction to normal. This early signal is moving towards V6, resulting in an initial positive deflection in this lead. Depolarization is discharged into the right ventricular muscle mass in a timely fashion through the intact right bundle, and as this signal is moving away from V6, we start to see a negative deflection develop in this lead. However, as this process is taking place, the signal finally reaches the left ventricle from the right side of the heart. The slow spread of signal through the left ventricle dominates all others, and as it is moving towards V6, it generates a second R wave in this lead. This QRS morphology is the broad M-shaped QRS complex in the left-sided leads, characteristic of left bundle branch block. The initial R wave reflects reversal of the normal pattern of depolarization in the septum, while the second R wave reflects delayed left ventricular depolarization. A very similar QRS morphology is produced in the left-sided frontal lead, lead 1. You should note also that the delayed signal from left ventricular depolarization results in deep, wide S waves in the right-sided chest leads, illustrated here in V1. These are the classical ECG findings described in left bundle branch block. However, just like right bundle branch block, although key elements of these morphologies must be present to make the diagnosis, the actual appearance of the complexes varies greatly between cases. In reality, the notch between these two positive deflections is frequently not as prominent as shown here. In this example, the M pattern is far less obvious. However, this is left bundle branch block, as the QRS complex is broad and predominantly positive in the left-sided leads, leads 1 and V6. An overall negative QRS complex with a deep, wide S wave in the right-sided chest lead V1 is also consistent with the diagnosis. Also note there are no Q waves in leads 1 and V6. This is at least consistent with loss of the normal early left to right depolarization of the septum. In practice, the main criteria for diagnosing complete left bundle branch block are as follows. The complete lack of concordance between QRS complexes and T waves in left bundle branch block should also be emphasized. In left bundle branch block, this is expected. The grossly abnormal pattern of depolarization produces secondary abnormalities of repolarization, with ST elevation or depression in various leads, and complete loss of concordance between QRS complexes and T waves across all leads. These changes are an electrical phenomenon secondary to the highly abnormal pattern of ventricular depolarization and do not indicate underlying acute ischemia or infarction. Block on an ECG is a highly abnormal finding. Significant damage to the left bundle branch is commonly seen in infarction secondary to obstruction of the left anterior descending artery. And new onset left bundle branch block may be the presenting ECG abnormality in a patient with anterior MI. Damage to the left bundle branch in this situation tends to be permanent following resolution of the acute MI, and the chronic ST changes associated with left bundle branch block then make interpretation of the ECG at any subsequent presentations with chest pain difficult. The left bundle branch may also be damaged in diseases causing diffuse damage to the left ventricle, for example hypertension, myocarditis, or cardiomyopathy from whatever cause. In addition, during part of its course, the left bundle branch has a close anatomical relationship with the non-coronary cusp of the aortic valve, and consequently left bundle branch block is seen in diverse diseases of the aortic valve. We have studied the ECG manifestations resulting from damage to different components of the conducting system in videos spread throughout this course. We will now briefly review the ECG diagnosis of conducting system abnormalities. Damage to the AV node or diffuse damage to multiple components on the right and left sides of the intraventricular conducting system impairs the transmission of atrial depolarization into the ventricular myocardium, manifesting as AV block on the ECG. AV block may be first, second or third degree. Isolated damage to the main body of fibres in one of the branches of the bundle of His results in left or right bundle branch block on the ECG. The PR interval is normal as depolarization is initiated in good time on the unaffected side of the heart. However, the QRS complexes are wide as depolarization travels slowly through the affected chamber outside the conducting system. The ECG patterns produced by left, or as shown here, right bundle branch block are predictable and distinctive. However, in the majority of individuals, the left bundle branch divides into three peripheral branches or fascicles. The two major subdivisions of the left bundle branch, the left anterior fascicle and the left posterior fascicle, depolarize the walls of the left ventricle. Because of extensive anastomoses between these systems within the walls of the left ventricle, when one of these major branches is damaged, the QRS complex duration remains within the normal range. However, the altered pattern of flow within the left ventricular wall manifests on the ECG as a shift in the cardiac axis. Left anterior fascicular block results in left axis deviation, while the more unusual left posterior fascicular block results in right axis deviation. As outlined in earlier videos, damage to components of the conducting system occurs secondary to many different pathologies. However, you will commonly encounter conducting system dysfunction in the setting of ischemic heart disease, and therefore it is worth knowing a little bit about the blood supply of the conducting tissues. As shown here, the AV node is usually supplied by a branch of the posterior descending artery, which is itself a branch of the right coronary artery in 90% of individuals. In clinical practice, AV node damage with first, second or third degree AV block is often a problem in inferior infarction or ischemia secondary to obstruction of the right coronary artery. The left anterior descending artery supplies the interventricular septum through septal branches. These vessels supply the right bundle branch, the main body of the left bundle branch and the left anterior fascicle of the left bundle branch. Anterior myocardial infarction may therefore result in blockage of conduction in either the right or left bundle branches, resulting in new onset right or left bundle branch block on the ECG, while left anterior fascicular block developing in anterior MI will give rise to left axis deviation on the ECG. In very extensive anterior infarction resulting from obstruction of the left anterior descending artery proximal to the origin of the septal branches, both the right and left side of the intraventricular conducting system may be damaged, resulting in AV block on the ECG, a very poor prognostic sign in anterior MI. terms aberrancy or aberrant conduction refer to any situation in which a depolarization wave is conducted through cardiac tissue outside established pathways. We've come across many examples of aberrant conduction throughout this course, both within the atria and ventricles. Examples of aberrancy within the ventricles include conduction of ventricular ectopics and conduction of ventricular depolarization in the presence of a bundle branch block. In these situations, aberrant conduction within the ventricles results in altered QRS complex morphology, with widening of the complexes beyond the upper limit of normal duration, as the depolarization wave spreads slowly by direct cell-to-cell contact outside the conducting system. There are other causes of aberrancy within the ventricles which you need to be aware of. So far we have considered bundle branch block as a permanent entity on the ECG. It is possible, however, for conduction in one of the branches of the bundle of His to fail on an intermittent or transient basis. This form of aberrant conduction can be very important when diagnosing arrhythmias. As with any electrically active cardiac tissue, depolarization of the right or left branch of the bundle of His is followed by a refractory period, illustrated here in red, when the tissue of the branches will not depolarize in response to further signals. Furthermore, the refractory period of the ventricular conducting system adjusts in response to the rate at which depolarizing events arrive. Specifically, the refractory period of the left and right bundle branches become more prolonged as the heart rate slows. Also, as illustrated here, the left and right bundles have slightly different electrical properties, with the right bundle branch having a longer refractory period than the left. And this difference becomes more pronounced at lower heart rate. For these reasons, it is possible for the right bundle branch in particular to be caught in a refractory state in the presence of a sudden, unexpected change in the rate at which depolarizing signal arrives through the bundle of His. The simplest example of this is seen in some cases of very early atrial or junctional premature contractions. In the example shown here, the heart is beating at 60 beats per minute. At this relatively slow heart rate, the refractory period of the bundle branches is prolonged, and the difference between the refractory periods of the right and left branches is appreciable. At this point in time, a focus within the junctional region has discharged, generating a premature junctional contraction. However, note that the premature discharge has occurred at a time when a region of the right bundle branch is still in a state refractory to transmission of depolarization. The initial events of the QRS complex associated with this premature discharge are conducted as normal through the left bundle branch and will depolarize the left ventricle in the normal fashion. However, once the premature depolarization wave encounters the refractory portion of the right bundle, the right side of the heart must be depolarized by signal traveling outside the conducting system. Aberrant conduction by direct cell-to-cell contact outside the conducting system results in a broad QRS complex with right bundle branch block morphology. How can we tell such an aberrantly conducted premature junctional contraction from a premature ventricular contraction? Well, in truth, often with great difficulty. However, as the initial events of ventricular depolarization occur as normal, the initial portion of the QRS complex of an aberrantly conducted premature junctional or premature atrial contraction will often be identical to the initial period of the preceding normal complexes. If the block is close to the AV node, this initial period can be very short. In practice, if a wide premature QRS complex is initiated in the same direction as the normal complexes, and this is observed in several leads, it is likely to represent an aberrantly conducted premature atrial or junctional contraction. If the complex is initiated in the opposite direction, it is likely to represent a premature ventricular contraction. Transient aberrant conduction may also be observed in atrial fibrillation. You'll remember that in this arrhythmia, the transmission of atrial depolarization events into the ventricles is chaotic, resulting in a ventricular rate that varies unpredictably with time. In the example shown here, note the chaotic generation of QRS complexes secondary to depolarization events arising in the fibrillating atria. At this point, a relatively long period between ventricular depolarization events has been followed by a QRS complex demonstrating evidence of aberrant conduction. What has happened in this case is that the bundle branch's refractory period have lengthened during this prolonged gap between ventricular depolarizations. An early transmitted atrial depolarization wave has then encountered the right bundle branch while it is in a state refractory to transmission. Aberrant conduction results in the presence of a broad QRS complex. Aberrant ventricular conduction of an early depolarization wave following a long RR interval in atrial fibrillation is termed Ashman's phenomenon. Although this may affect either bundle branch, as shown here, the transient block usually occurs in the right bundle, and the aberrantly conducted complex therefore usually demonstrates a right bundle branch block morphology. A transient failure of conduction can also develop in either bundle branch in response to elevation of the heart rate. Acceleration or rate-dependent aberrancy refers to a failure of conduction in a bundle branch when the heart rate rises to a certain level. In this patient with known heart disease, at a heart rate of 60 beats per minute, the ventricular conducting system is fully functional, with narrow QRS complexes on the monitor. As his heart rate begins to rise, note that after a short period of time at a rate of 96 beats per minute, conduction in the left bundle branch fails, and he develops a left bundle branch block pattern on the ECG, resulting in broad positive QRS complexes in V6 with associated ST changes. Acceleration-dependent aberrancy can be observed in normal hearts at extremely high heart rates. However, it is usually a marker of organic heart disease, and in such individuals can be observed at surprisingly low heart rates. In individual patients, it may be triggered on reaching a given heart rate, or may be dependent on the time spent at a higher heart rate. You will appreciate its importance. Patients with organic heart disease are subject to arrhythmias. If a patient prone to this phenomenon develops a tachycardia from a supraventricular focus, failure of a bundle branch at the higher heart rate will result in broad QRS complexes on the ECG. Differentiating such an aberrantly conducted SVT from a ventricular tachycardia is important, as in hemodynamically stable patients, the treatment of these arrhythmias differs.